Hello, everybody. My name is Benjamin Day,
And I am Jillian Mason.
and this is Medicare for All, the podcast for everybody who needs healthcare. So,
Woo!
just this Monday, this week, we celebrated Martin Luther King Day, a tribute to obviously one of the great leaders of the movement for racial justice. I mean, I hear he was at least like an okay leader for racial justice.
I've heard things. It's a word on the street.
Yeah. But something that, often gets forgotten in the flurry of all the, MLK quotes that become memes this time of the year is that equity in healthcare was, a crucial part of King's vision and the vision for civil rights at the time. Throughout his career in activism, he often stated his conviction that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. You can actually get that on a Healthcare Now poster if you would like from our store. But sadly, 50
It's a
years.
weird place for a sales pitch.
I know. Well, is there really a right place for a sales pitch? It's always wrong.
Good point.
Totally self-serving moment there from Healthcare Now store.
And okay merch.
But as we all know, unfortunately, 50 years after his death, racial inequality in healthcare is even more shocking and even more inhumane, arguably. So today we are joined by public health expert and healthcare systems expert, Dr. Walter Tsou, to do a deep dive into the horrifying world of racial health injustices, sort of how we got here and how we can make a real change. So, Jillian, do you want to introduce our guest in a little more depth?
Yes, absolutely. So Dr. Walter Tsou, aka Walter, is a past president of the American Public Health Association and also the former health commissioner of Philadelphia. I mean, Walter is actually very legit. He's an expert on healthcare reform and healthcare financing, and he frequently briefs members of Congress on healthcare issues. Walter received his medical degree from the University of Pennsylvania and his master's from the Johns Hopkins School of Hygiene and Public Health. He's a board advisor to Physicians for the National Health Program, who are our allies in the fight for Medicare for All. But most importantly, Walter serves on the board of directors for Healthcare Now. So he's our boss.
Yep.
Thank you for coming today, Hefe.
Well, thank you so much, Ben and Jillian. It's such a pleasure to be part of the best podcast on the internet for Medicare for All.
You heard it here first. We're going to tell all the other Medicare for All podcasts how much they suck. Put your quote on our webpage.
That's right.
No, that's excellent. All right. Well, we really appreciate the testimonial. I do want to talk more about your we mostly Walter, when we get together with Walter, he's yelling at us for not fundraising enough. But so it's nice to have this opportunity to get to know you a little bit better and hear a little bit more of your story. So when I was prepping for this episode, though, I thought, Walter is like a public figure. So there's probably some trace evidence of his public life. And so I actually went back and did a newspaper search for you. And I found that back in 1974, when you started medical school, the Philadelphia Inquirer did a little interview with you. That's correct, right? This is you,
that
right?
Is true. Yes. Oh my God.
Okay, so
it's incredible.
I would just like, before I let you, I'll let you address all of these issues, Walter, but I just want to point out some things first. This is what the Philadelphia Inquirer had to say about you, Walter, back in 1974. Walter Tsou, 21, chemistry major at Penn. Walter has known since high school that he wanted to be a physician and has worked diligently toward that goal. He laughs easily, wears University of Pennsylvania streaking team shirts, and jokes often.
Okay, I've been found out.
There's going to be follow-up questions. There will be follow-up questions.
So I thought that was pretty good, and it's interesting. They actually followed you throughout your career, right? And they related this one scene that I thought was really funny. They're talking about you doing your some of your exams, and you said it's like taking the first 100 pages of the Philadelphia telephone book and deciding to learn them. And so the reporter asks you, "Are you worried about the exam?" And you say, "I'm not uptight about it."
No, I said that.
Yeah, very cool 70s answer. I'm not
Yeah,
uptight
cool,
about it,
right? Yeah.
right? But then someone chimes into the background. "You're not," snapped Barbara Turner, who is one of the 6-member dissecting team at this table. "You must have changed a lot since last week."
Oh, called out.
Oh wow.
Oh man.
I've
So
been
yeah.
called out, yeah.
So I got to find out some of those things, but I thought maybe you could pick it up from there and talk a little bit about, just like how you developed this passion for healthcare, and in particular the kind of equity issues in healthcare that you really spent your whole career on.
Yeah. Well, thank you for the question, because it's appropriate to start in medical school. Yes, I did go to Penn Medical School, one of the best schools in the country. And I should tell you that in my 4 years in medical school, I received no training in public health. So that I literally went through medical school, no role models, no one really who discussed public health. And when I did my residency, I did it in internal medicine, also not far from Penn in West Philadelphia. And after I finished my residency, I was looking for a job, and I thought, some attending would come over and put his arm around my shoulder and say, "You look like a bright young man. Why don't you join my practice?" And I would go into private practice in internal medicine. And what happened was it never happened. Nobody put his arm around me, so I had to find another alternative. And one of my fellow residents said, "There's a public health clinic up the street. They're looking for doctors. Why don't you work in this public health clinic in West Philadelphia," which is a very poor area of Philadelphia.
We all know that from Fresh Prince of Bel-Air.
Yes, that's right.
In West Philadelphia, born and raised. Yeah, sorry.
Also, where Quentin Brunson is from too, who just got the
Emmy.
Oh,
nice.
So
nice.
Anyway, I said I would do that. I worked, and I thought I'd kill a year, and then I would try again to go into private practice. And after I got to the public health clinic, it was totally different from what I expected. I mean, literally every day, people would come up to me and say, "Dr. Tsou, if you weren't here or this clinic wasn't here, I don't know how I would pay for my meds. I don't think I could pay for a doctor's visit and put food on the table." And I thought, wow, that's really pretty profound. And then I started thinking about it and realized that government had created this public clinic for, what they call the uninsured and the poor. And most of my friends and ourselves would go to private doctors to get our care. And, it's pretty striking that we have this overtly two-tiered system that was happening between the public clinic and the private sector. And I started getting more curious as to why that was true. And I didn't know a whole lot about public health because I didn't learn anything in med school about it. But I started actually liking the idea that I was using my medical knowledge in a way that was really quite beneficial to a very vulnerable population. And
so I guess
from that, I started realizing that, there's something wrong with how we finance healthcare in our country. I don't know, Ben, you want to say something?
No, I was, and I like when life stories are mostly accidental, since I feel like most of the good ones are. But you accidentally were put in a position where you kind of saw all the problems kind of exposed. So.
It's kind of weird. I just when we talk to folks, particularly from like your generation, Walter, right? Who have come out of medical school during the time period when you were in medical school, folks say the same thing, right? That they had absolutely no training in equity or in public health in general. And so it's interesting to me just how much of this was like self-driven for you. It was like you discovering inequity and trying to discover new ways of fixing it. I just think that's so cool.
Yeah. Well, subsequently I've taught in public health back at Penn, ironically, and
Mm-hmm.
also
Mm.
in other public health programs. And periodically I'm asked to mentor other students,
Mm-hmm.
and a lot of them feel directionless. And
Yeah.
they often say, how do I know where I should go?
Mm-hmm.
And one of my colleagues in public health school said to me, if you want to find the direction you want to go, find out what breaks your heart,
Mm-hmm.
because what
Hmm.
breaks your heart is going to be something that will inspire you in many ways for the rest of your life.
Mm-hmm.
And that experience working in a public health clinic, and the fact that these people were so desperate to get care, and the fact that the system was so, overtly discriminatory,
Yeah.
Yeah.
that
Yeah.
sort of broke my heart. And it's the
Mm-hmm.
reason
Yeah.
why I think I have pursued public health and health equity or health justice my
Mm-hmm.
entire career. I just think that we have to
Yeah.
right this overtly wrong and crazy system. And as
Yeah.
Ben pointed out, in some respects, it's actually gotten worse, not better, since the time I was there.
Yeah. So
Yeah.
let's fast forward a little bit, because you served for a while as the health commissioner for Philadelphia, and we're going to get into the broad topic kind of racial inequities in healthcare nationally. But I'd be curious if you could give us kind of a more on the ground view of when you were doing that job as a health commissioner for Philly. What did the racial inequities in the health in, I guess, both public health and access to healthcare look like in the Philadelphia setting that you had to deal with as commissioner?
Yeah, well, that's a very important question. And probably no statistic is more clear cut in terms of inequality than infant mortality.
Right.
The black infant
Mm.
mortality rate when I was there was something like 15 or 16 infant deaths per thousand.
Mm-hmm.
And uh, for the white population, it was something like maybe six. So
Mm-hmm.
it's three times, almost three, 2.5 to 3 times worse.
Mm-hmm.
What's striking is that not only is it that wide a disparity then, but I just looked up before this broadcast what the infant mortality difference is today, and it's still 2.5 times
Right.
greater for
Mm-hmm.
black infant mortality.
Mm-hmm.
So that for all that we have talked about in health equity, all the programs that people are saying they're trying to, that we value children and all this other stuff, the black infant mortality rate still is twice to two and
Mhm.
a half times greater in Philadelphia than that of the white infant mortality rate. Yes, it's gotten a little bit better, but the disparity remains. And you have to ask yourself, why does it exist like that?
Mm-hmm. Mm-hmm.
Given
Yeah.
the fact
Yeah.
that we have one of the most advanced medical systems in the world, reportedly, we still have this incredible disparity between black and white
Mhm.
infant mortality. And that sort of plagued me in terms of when I was health commissioner. And I think anybody who is concerned about public health, you have to start with the very beginning in
Yeah.
terms of how we're
Keeping
treating
babies
kids.
alive,
Yeah.
right?
Yeah, like
I
keeping
mean,
kids alive, right? Babies
yeah,
alive.
yeah. That feels really important.
Right. You would think of all the things that you would think that would be a politically uncontroversial public goal, right? Keeping
Yeah.
babies alive. Did you feel when you're commissioner like you had the tools to address inequities like that at the city level, or did it really have to be large scale systemic changes in national legislation, state legislation, and city commissioners were really just kind of sticking their fingers in the dam?
Yeah. Well, this goes to this whole term of health disparities and health equity. And traditionally, a lot of politicians say, well, we're going to do something about health equity. And we're going to create an office of health equity, and we're going to put it in the health department. And,
Mm-hmm.
in Pennsylvania, for example, we had an office of health equity when it first opened. I think it had 2 people in the entire department
Right.
for the entire state of Pennsylvania. I mean, think about that.
We're still trying to get one in Massachusetts. I don't think we even
Yeah.
have an Office of Health Equity.
But
I'm gonna guess
I want to
Texas is
point
a
out
no-go
that
on that.
when you think about what is involved with trying to really address infant mortality, that disparity, you are talking about the larger social determinants of health.
Mhm.
And where should that Department of Health Equity really reside? Should it be in the health department? Absolutely not. This should
Mm,
be in the president's office, the governor's office, the
mm,
mayor's office. It should be the very mission statement of what government is about.
mm,
Because to understand how are we going to reduce that huge disparity, we have to address the social determinants of health. We have to look at education, job opportunities, housing, transportation, all the things that we know can and will make a difference in terms of trying to reduce those disparities. And to put 2 people or 4 people in the health equity office in the health department is
Right.
window dressing. It doesn't.
Yeah.
It's you're not
yeah.
taking seriously. I mean, this is exactly what government should be about at the highest level if
Mhm.
we're really serious about reducing those disparities.
That
Yeah.
makes a lot of sense.
I,
Yeah.
I feel like that when you start thinking about social determinants of health, the more you take a realistic scientific approach about making change, the more radical you have to become. Right? You
Yeah.
really have to overhaul all social inequities in our society, across all those major systems that you were talking about, and you have to take on more and more kind of industries to win. But I
Well,
think that's the reality of it. So
I mean, uh, our public health department, um, it has. I mean, the things that really work in other developing countries. Let's start with that.
mhm.
Are the
Mm,
community health worker movement, the people who are on the ground, who are helping to check on people in the neighborhood. In
yeah.
Philadelphia, many years ago, during the Johnson administration, the Great Society, they used to have public health nurses who were
Mm,
geographically assigned to neighborhoods in the city, and
Mm,
they would literally go out in their nurse caps and capes, and they would be very recognizable.
right.
And they would walk through the neighborhoods. They didn't have guns. They weren't police officers. They weren't going to take the kids away from their parents. They were
mm,
people who were viewed strictly as being helpful. They would do well baby checks. They'd give
Mm,
immunizations to kids. They'd wake people who were malnourished. And the drug addicts even would say, listen, there's someone who's sick in my crack house. Why don't you come on in? And they would invite
yeah.
them in. They're the only ones who could get into these homes.
Yeah.
These
Yeah.
public health nurses and these community health workers who come from the neighborhood. Well, do you think the health department gets a chance to hire people like that? No, we don't make that investment because we spend all this money on this other crazy stuff. I mean, for the price of one MRI machine, I could probably fund the entire community health worker program in
right.
Philadelphia
Wow.
for several years. And
Mhm.
that goes to
Wow.
show you how ridiculous
Priorities.
our priorities are if we're really serious. And if we
Yeah.
actually had such a community health worker program where government is actually viewed as a trusted player and are actually in the community, what a difference that would have made in the beginning of, let's say, the COVID pandemic or
Yes.
Right.
any number of efforts that we're trying to get in the community and listen to the voices of what the community wants. We don't we don't have that capabilities, but
Yeah.
public health is the entree to do that, and we don't fund people to do that kind of work.
Right.
Other countries do that. Other countries make
Mm,
investments in community health workers, in barefoot doctors, and other things like that, and we don't. And it's labor intensive, yes, but it's actually far cheaper than a lot of this high tech stuff that we waste our money on. That really does very little to reduce the huge disparities that we have in our country.
Right.
I could go on. You can see.
Yeah.
Yeah.
Unfortunately, there's a deep well of horrifying realities about racial inequity.
Yeah, but we can
Um,
circle back to this also when we talk about Medicare
yeah.
for all and inequities too, because I think what you're saying, the lack of really any community health work or very very little community health work is linked to how we pay for the healthcare
Yeah.
system and
Yeah.
how
Yeah.
providers kind of see their job and patients and don't see themselves as part of their community for the most part. But yeah.
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 Yeah. As you said, right, the United States hasn't invested in these programs, right, that a lot of other countries in the world have. And really that's, one of the reasons why we are where we're at. And so I did want to kind of like back up for a second and talk about like where we actually are right now in America. For folks who are not familiar with like the gory details, I know, Ben and Walter and I think about this every day, but you might have other shit on your mind. And so let's just talk a little bit. The Commonwealth Fund is a great organization that does research in all different areas of equity in the U.S. And they did this like little scorecard basically in 2020 about sort of a snapshot of racial and ethnic inequality in U.S. healthcare. So we want to kind of go through and just like give you guys some of the stats that back up this kind of general sense that I think that everyone feels, right, that there's something desperately wrong here. But here are some of the numbers, right? Ben, did you want to run through that for folks?
Sure. So at a very high level, Walter was talking about life expectancy with infant mortality, but life expectancy shows that Black and American Indian, Alaskan Native people live fewer years on average than white people. That Black, American Indian, Alaskan Native individuals are more susceptible to chronic diseases, kind of across the board, especially the ones like diabetes and hypertension that have just real dramatic impacts on your quality of life and your health outcomes. There are higher rates of pregnancy-related complications for people of color, much higher infant mortality rates, which Walter's already talked about, and we talked about in our episode on maternal health. There are poor health outcomes that are obviously driven by higher poverty rates, higher risk environments, less access to healthcare in communities of color. People of color are less likely to have health insurance, more likely to incur medical debt, and have more cost-related barriers to care and less access to preventive care. It's hard to even go through the whole list, but I'll go through a few more of the high-level ones here. But Black women are more likely to be diagnosed with breast cancer at later stages and more likely to die from breast cancer than white women. Black Medicare beneficiaries are more likely than white beneficiaries to be admitted to a hospital or to seek care in an emergency department for conditions that are typically manageable through good primary care. And then finally, this is obviously really relevant for the last few years, there are lower rates of vaccination among all the different communities of color. Black, Native American, and Latinx adults much likely than white adults to receive an annual flu shot, for example. So, Walter, how did we get to this point? Thinking kind of historically about this, how do you think about the history of racial inequities in healthcare and how they kind of led us to that long list of shocking outcomes in kind of every area,
Yeah.
Well, the original sin of 1619 when we brought slaves to this country was our statement of devaluating one class of people based on race. And race actually is the theme that probably pervades all of American history, even to this day.
Right.
We have a long history, obviously we fought a civil war around this. We had reparations, we had Jim Crow laws. We have made, some efforts to try to remedy that, but, and we had redlining, of course. But the disparities in income, the opportunities in a market-based capitalist society for people who don't have as much money to get the best education, to get in turn the job opportunities that you really need to really advance.
Yeah.
All that has really suppressed Black and brown communities in America.
Mhm.
And when you tie a healthcare system to a market-based approach to healthcare, which
Right.
we do, it's not surprising that if you don't have a whole lot of money, you're kind of like cut out of the system. So all those
Yeah.
things that you mentioned about uh, less, higher uninsured rates among Black and brown communities, about their ability to get access to care. And then, of course, we had Tuskegee, this
Mhm.
where the episode of this experimentation that was done in patients with syphilis, and we tried to justify not treating people in sort of this research experiment. Well,
Mhm.
you've engendered this enormous distrust. So imagine, if you will, that an entire several generations of Americans have been priced out of our healthcare system, have
Mm.
been distrustful because of Tuskegee and the sense that they're being experimented on.
Mhm.
And now all of a sudden we have this pandemic, COVID,
Hmm.
and we tell people, hey, come in and get your vaccine.
Mm.
Trust
Oh,
us,
guess
right?
what? We're trust us. We're not going to
Right.
charge you or anything. And you know what? And all, by the way, the healthcare system that you've been priced out of, suddenly we're going to see you in our emergency rooms
Mhm.
and
Mm.
trust us that you aren't going to get charged a lot of money for this. Well, you know, these people are going to say to you, "What are you, crazy? Why
Yeah.
should I trust this totally discriminatory, overtly ridiculous system that we have?"
Mhm.
And so I'm not surprised that we did not do well in terms of trying to overcome the huge discrimination stigma that has been part of the American healthcare system. And
Yeah.
and as a result, I think that's why lots of people didn't get their vaccines, and a lot of people still do not trust our American healthcare system. They've learned over time that the only way you get healthcare is you get so sick that you have almost no choice but to show up in the emergency room. But short of that,
Mhm.
you you don't have a real primary care relationship. You don't have a sense that you can check on being a worried well person.
Mhm.
So
Uh,
that is really one of the aftermaths of this long history of overt discrimination, both economically, socially, educationally, that we have fostered in our society, and it's reflected in these terrible statistics that you mentioned.
Mhm.
mm. It's also reflected, right, Walter, in the actual structure of our public health systems, right? So like the origins of Medicare and Medicaid, right? They also were very much shaped by racism, right?
They were, and but actually, it's interesting that the Medicare system was one of the ways in which we were able to desegregate parts of the particularly southern hospitals.
Right.
If you look at
Mm.
Grady Memorial Hospital, even to this day in Atlanta, Georgia, it is literally a symmetrical building. The left
Hmm.
side was for white patients, the right side was for black patients. It was the manifestation of
Uh,
separate but equal.
Hmm.
And the waiting rooms in most doctors' offices, there were either curtains for the blacks separate from the whites, or they had separate entrances.
Hmm.
And when the Medicare program was actually instituted, and this is all documented in a book by my good friend David Barton Smith, in a
mm.
book called The Power to Heal, and it's also a movie which I recommend. Um, you could see that Medicare basically said, if you want our federal dollars, you will stop this discrimination in your waiting rooms and
Right.
this two-tiered discriminatory separate system in your hospitals.
Mhm.
And
Wow.
until Medicare put its foot down like that, uh, those southern hospitals in particular had refused to actually agree to do this.
Wow.
So in many ways, this is an example of how a universal healthcare system like Medicare, using its influence and power, could actually help address the racial disparities that was happening in Southern hospitals and waiting rooms.
Yeah, that's such a great point. We're sitting here, we're talking about race and healthcare. I know from experience dealing with the single payer movement, right, that in the past, folks who wanted to talk about race and healthcare in our movement may have been marginalized a little bit, right? We sometimes, when we bring up the issue of race, when we talk about healthcare, we get people saying, oh, well, it's Medicare for all, right? Which is, I think, the Medicare for all equivalent of All Lives Matter, right? It's basically, this is about everyone. Why would you bring up race? That makes it divisive, right? And this obviously we think is bullshit, right? And we think that we should all be talking about race all the time because, like you said, Walter, it's the original sin and it's the driving factor that shaped all of American social policy. But I think that, that has become more acceptable and more in our culture since like the Black Lives Matter movement, right? Like it's raised the visibility of racial issues, made it like more common to talk about race. And that's been particularly in areas like criminal justice and policing. We were wondering, do you think, Walter, that the BLM movement that's really just like raise the visibility of racial analysis in our culture, do you think that that's influenced at all the way that the public sees healthcare in this country? Or do you think those things are sort of divorced in people's minds?
Well, I'll start with a disclaimer by saying I'm not Black. So I won't, I don't want anyone to misconstrue that I can truly speak for the total Black experience. But I have many friends who are Black, and they will tell you that most white people, let's put it this way, never really think about their race in their society.
Yeah.
But there are studies that have looked at how Black people see their everyday lives. And for them, they are conscious of their race on a daily basis. That is a very difficult concept, I think, for many of us to fully understand, that you're always aware that you're different in our largely, white-dominated society. I think that if we got Medicare for all, it would be a step, and a huge step, in trying to help level the playing field in many ways in terms of healthcare. But it is not this solution by itself. There's going to be a huge concerted effort that needs to be made to make sure and to make sure that people really know their rights under the system, and that they really have equal access and opportunities, at least to healthcare services. Mm-hmm. It doesn't necessarily address many of the social determinants of health. There could be still discrimination in education, housing, job opportunities, which are profound. But it would go a long way toward helping to give people a sense that we are all Americans, Black, white, rich, poor, young, old, suburban, urban, and that we all have a right to come in to a healthcare system that we can call our own.
Right. Yeah. And you had said earlier, Walter, that, obviously you had said our healthcare system is based on kind of a capitalist, money-driven system, but very specifically, it's based on the job market, where you get work, if you can get work, and how good your healthcare coverage is through your job. And also, if you don't get it through work, then you can just buy insurance on your own. So that's income driven. So we have a healthcare system that is minimally linked to the job market in the United States, and it's linked to sort of access to resources and assets. And so as long as those are linked, then any racism that exists in the job market gets replicated in the healthcare system, and any
Mhm.
racism that exists in access to sort of, generational resources and income, that also gets replicated into the health insurance system. So at least with Medicare for All, we would delink those racist systems. But like you were saying, that wouldn't address all of, especially the social determinants of health. You don't necessarily get all of that. You don't address all of that just by having a universal healthcare system, but you could at least disconnect some of these like systems that are feeding on each other and amplifying the challenges in accessing the care that we need or being able to afford care. So,
And that would be a huge
yeah.
step. Absolutely. It's one of the reasons why, all of us are fighting for Medicare for All, because we realize it's a huge step. It's a big lift. And it also it's a statement about how we value each other, at least within our healthcare system. It's hard for us
Yeah.
to talk about health equity and try to, which we define maybe as the highest attainment of healthcare, regardless of one's station in life, rich or poor, black or white, you know, uh, and believe that you can reach health equity with all these employment based health insurance or resource based health care that says, if you have HIV, you get certain benefits, but if you have colon cancer, you don't. I mean, that's how our system. If you're a veteran, you get some things. You're elderly, you get some things. But if you're sort of in the middle, you're screwed. I mean, what kind of stupid discriminatory system is this? That's what we have in America, and of course, it replicates all the disparities that we're talking about.
Yeah, and this may be a somewhat controversial statement on my part, Walter, but I feel like
we love we love controversial statements.
I mean, I feel like racial inequities in healthcare are probably more deadly than racial inequities in policing. Lead to more deaths and more suffering. But I feel like the level of awareness of that is not as high as the awareness of, and just there's not the same public debate over racism in policing. I don't know if you feel the same way about that, but I guess there's no need to compare, but yeah.
It is really remarkable to me that if we had a rally for Medicare for All in Washington, D.C., we'd be lucky to get 1,000 people to show up. With climate change, you can get 500,000 people show up and march. For Women's March, you get 500,000 people to show up. For Medicare for All, we get 1,000 people. The ability for, or let's say the disconnect between how serious this issue is, how overtly discriminatory the system is, and our inability to be active on this is always striking to me.
Yeah.
And I think somehow or another, that's why we have healthcare now. That's why we have all these other groups who are saying, the current system really sucks. It's really overpriced.
It is deadly.
It costs too much. It covers the few. It hurts too many people. And we need to fix it. And more and more people need to wise up, because part of the reason why this nation is $34 trillion in debt is because we have been propping up a dysfunctional healthcare system, borrowing tons of money to fund all these dysfunctional healthcare systems, and funding the middleman, the private insurance companies, the PBMs, the private and funding them to the tune of billions of dollars. And no wonder we're out of money. Other countries don't do that, and they are able to actually fund much more of their infrastructure.
Yeah, we would probably have like a Swedish social welfare state if we weren't paying for so much money for healthcare. We could have all the other things, right?
Because we're a larger population, we could do it for even cheaper tax money than Sweden does.
Right.
Yeah.
So,
yeah. Ben always says that, like, for like conservatives, for people who are like really pro like war and incarceration, that they should be for Medicare for all, because then we would have more money to spend on war and incarceration.
That's right.
That's right.
Which I think is an interesting way of arguing it. But also, I should say that
Don't do
healthcare
that.
now is officially for less money for incarceration and war. But so, all right, so we got this Medicare for All movement going. We got a bunch, like you said, of organizations, PNHP, which you're very active in. That's Physicians for a National Health Program, which is awesome. These are, doctors who are like speaking out about our health program. We have the Labor Campaign for Single Payer, which is one of our amazing advocates that organizes union workers around these issues. We've got Healthcare Now, where we organize everybody else into, to speak up about these issues. Right. So we've got this movement going, but we know that movement needs to be accountable to these issues that we've been raising today. These racial equity issues. So my question for you, Walter, is, as someone who has worked in public health, how can Medicare for All activists be more effective allies and advocate for universal health care with the issue of racial equity front and center?
Well, the obvious start is that we work with other racial equity groups, and there are many in this country who are very interested in getting health care for their groups. The NAACP, the Asian Pacific Island American Health Forum, La Raza, any number of groups are out there who want to try to improve the health of their respective communities, and we need to be working with them to raise the issue about why Medicare for All program is in the very best interests of their constituency. There is no politician out there who does not hear on a daily basis some complaint about getting access to healthcare services.
Right.
And every time I ask a politician, well, why don't you support single payer? At least if we give you a chance to help address this issue. They say, they don't think it's realistic. It won't happen. Well, as Ben said recently on a podcast, I mean, you're the government. You're the people who make the decision about whether things are realistic or not. You can change the equation.
Yes.
I mean, that's why we elect you.
I think I know the Philly representatives you're talking about there, Walter. We have a few tough ones that need an extra push.
Yeah. Sorry. It's right. The government does have the ability to decide what's realistic and what's feasible, and they do it all the time for shit that's way crazier, right? Like, I mean, they decided they wanted to build a border wall, and people literally went down there and started to build a border wall. That is insane. Right.
Yeah.
The idea that that's realistic and healthcare is not realistic, to me, is like mind blowing.
Maybe we should just go down there and build a Medicare for All system.
Just go down and build it. Yeah. Like
we just need some enterprising activists.
Actually, the drug companies want to build the wall so that people don't go down to Mexico and get cheaper drugs from. They're stuck with the American drug pricing.
As a Texan, I am thinking about that a lot.
Yeah,
a lot. Actually,
yeah.
As long as there's a ladder on our side of the wall, you can get those drugs.
Jesus Christ. Well, so Medicare for All activists, obviously, as Medicare for All activists, like you say, Walter, we need to be, front and center in the fight for racial equity, and vice versa. We need people to be thinking about Medicare for All as part of the fight for racial equity. I thought maybe we could close on just like, just thinking, because you're a doctor, right? Yes, you are a doctor. Okay, yeah, okay, great. Yeah, so you're a doctor.
I checked. I
covered that.
So what is it that doctors can do to support Medicare for All?
I
And
thought you were
how-
going to ask for a diagnosis. Since
Yeah,
you're a little bit
right.
sniffly.
I'm a little bit sniffly. I have some sore throat.
You have a cold.
God damn it, Walter. You can do better than that. Um, yeah, no. But so I
No,
forget
what
the
can
question I was
physicians do
asking.
to
Just
help?
tell me what's wrong with me.
You were asking what doctors can do to advocate for
What
racial
can-
equity in healthcare.
So
Yes.
yeah, this is a two-part question. What can doctors do, and how can patients talk to their doctors to get them more involved?
Interesting.
Yeah. Well, first off, there are a lot of doctors who are surprisingly in support of single payer. Almost on a daily basis, doctors are getting burnt out by this market-based approach to healthcare, and they don't really know what to do. Some of the conservative ones sort of are. They have what I would call learned helplessness. You know, they kind of are sitting like the frog in the boiling water and just sort of
Right.
accepting the fact that they're sort of going to get destroyed. But
Right.
they're unwilling to take up arms. And then there's a younger group of doctors, I think, who are willing to say, this system sucks. This
Right.
system is not what I went to medical school for. I don't want to spend all my time sitting in front of a computer screen when I should be talking to patients, examining them. Nobody does physical diagnosis anymore. They don't even know how to do that anymore. They just learn to hear a few symptoms and then order some lab tests and diagnose. And no wonder the healthcare system's so expensive. People don't take good histories anymore because it
Yeah.
takes time to do that.
And
And
Walter,
the
you
truth is-
mentioned at the beginning that you had no public health training in your medical school education, and I hear from med students even today that they're not educated at all in the healthcare system they're going to be working within.
Absolutely.
And that often ends up being more of a challenge to doing their job than being good at being a doctor. So, but
Yeah, and that is a failure of our health education system. Frankly, is that we don't teach the system that they're about to become immersed in,
right,
like the frog in the boiling water.
right,
And we have to actually get more doctors to speak up and say, I want Medicare for all. There is, of course, Physicians for a National Health Program. People can join PNHP, which is something that I've joined for more than 3 decades probably, that I have been part of. And that was inspired by the fact that I worked in this public health clinic, and one of the doctors who worked in that clinic told me about PNHP, and I joined not knowing anything about it and realizing that these people have a vision that is closer to what I think healthcare should be like. And the more doctors, I think, who are willing to talk about it, are exposed to it, the more we're willing to think about it. At the last Pennsylvania Medical Society meeting, which is the Pennsylvania arm of the AMA, we had a vote as to whether we will endorse single-payer Medicare for all.
Interesting. How'd it go?
And 41% of the House of Delegates said they would. 59% said they were opposed. But the point here is that it is not uniform 100% opposed. There was 41% of conservative doctors who said we need to have a single payer system. And I think as more and more doctors get burnt out, more of them realize and then we educate them about how terrible the current system is, more of them are going to join PNHP or at least overtly speak out for a single payer. So I'm not giving up on that. And as far as what patients can do, broach the subject. Talk to your doctor about it. Tell your doctor, don't you think it would be better that I could afford my medicines if we had a single payer system? And if the guy looks like he would agree with you, you should hand him a brochure or tell him about PNHP and tell him that you need to join us, because I think that we need more doctors to support single payer.
I once was in the middle of an appointment with a dermatologist who was holding a scalpel and asked me what I did for a living. And I said, I work at Medicare for All organization. And he said, "Oh no, I don't agree with that." And he started giving me arguments about why not. And I was like, I don't think I can make my case at this moment. I'm not going to tell you where he was cutting, but it was a part it was an area I didn't want to lose. So,
maybe pick and choose when to have those political conversations.
Yeah, do a little bit of subtle fishing first, like Walter was saying, and then if they seem receptive, then go for the kill. But be very careful, yeah.
Oh man.
Well, the answer is ask them about single payer after they do the procedure.
Yeah, that might be wiser.
Oh, I love that. I think that's awesome. Most of our listeners, of course, are not doctors and nurses, and I think that they just I think that people feel like you can't bring it up or whatever. But I like you just politicize the exam room a little bit.
Yeah, no, but
right.
You'll be surprised at how many doctors would agree with that.
Yeah.
I think you'll find it much more prevalent than you might realize.
That's some hope.
Yeah, especially in primary care and mental health and certain fields where they really see it the worst, I think. So, Walter, thank you so much for being here and lending your wisdom and your sense of humor and all that, and all the kind words.
For inviting me.
And telling us how great our podcast is. That was really the best thing you said.
Yeah,
in the whole interview.
Yeah.
I mean, racial equity is important,
that.
but the podcast is too. So, on that note, I want to thank our podcast team, and we're going to have some changes to the podcast team coming up this year as well. We're going to have some new folks joining the team, new researchers, new audio editors. So stay tuned for that. But this is our old trustworthy crew on this episode. Our podcast manager is Angelique Davis. Our researcher for this episode was Sophia Simeon. Our show notes writer was Jerry Katz, and our audio editor was Christian Brandt. So thanks so much to those. And don't forget to like this episode, subscribe to the Medicare for All podcast on whatever your favorite platform is. And the show is a project of the Healthcare Now Education Fund. So if you want to support our work and let us continue making this podcast, which is the best one out there on Medicare for All, you can donate at our website, healthcare-now.org. Thank you so much, everyone. Can't wait for another amazing 2024 season of episodes coming up.
Absolutely. Stay safe and stay dangerous.